Now that we've laid the groundwork, we can move on to the fun part, which is clinical assessment and diagnosis, and we'll do that primarily by going through cases. The 3 cases we're going to talk about are listed below. As you read through, it's worth noting that all 3 of these patients have the exact same serum sodium concentration, but each likely has a different volume status based on what's written here. This should again emphasize the principle that the sodium concentration in itself says nothing useful about the volume status of the patient. Now, before we jump into the cases, let's outline an approach that we can consistently apply when we're faced with the hyponatremic patient. On the initial bedside assessment, what we first want to ask is the patient symptomatic? The symptoms of hyponatremia can be vague, but commonly include headache, malaise, nausea or vomiting, and in more severe cases can present as seizure or respiratory arrest. The cause of all of these symptoms is brain swelling. As the extracellular tonicity falls, an osmotic gradient is created for water to move from the extracellular compartment into the intracellular space, and this can cause cellular swelling. Most cells in the body are able to handle this without issue, since they can expand relatively freely. However, brain cells are enclosed within a fixed space within the skull, and thus even minimal cellular swelling can lead to these symptoms. It's important to keep in mind, and we'll talk about this more later, that the severity of symptoms is more so related to the acuity with which the hyponatremia developed, and not as much to the absolute sodium concentration itself. After assessing for symptoms, I'd encourage you to take a quick look at the serum glucose. Most inpatients have some basic lab work readily available, and if the patient is hyperglycemic, and based on the math we went over before, you determine that the hyponatremia is being caused entirely by hyperglycemia, you determine the cause and you're pretty much done. Next, we move on to the most important part of the assessment, which is the history and the physical. Keeping in mind that decreases in effective circulating volume can cause non-osmotic ADH release, your history should focus on assessing for sources of volume loss or conditions that can lead to a decline in effective circulating volume. You should ask if the patient has had any GI losses like vomiting or diarrhea, excess urination, blood loss, and of course if the patient has a history of or symptoms consistent with known causes of hyponatremia, as an example congestive heart failure or cirrhosis or lung pathology, as we'll discuss more coming up. It's also important to thoroughly review the medication list, as numerous medications are known to cause hyponatremia. Common offenders include thiazide diuretics, antidepressants, in particular SSRIs, mood stabilizers such as carbamazepine and oxcarbazepine, and some antineoplastic agents as well. For your exam, you should focus on volume status, looking for signs of hypo or hypervolemia, as discussed before and listed again below. So now we've completed our bedside assessment, and we need to incorporate the data we've gathered into a useful approach. So here is an all-inclusive, frighteningly complicated algorithm that I'm sure most of us have been exposed to, or at least something similar, at some point during medical school. And I'd encourage you not to worry about charts like this one bit. Instead, use the data you've gathered and think of what additional data you may need to answer the question, why is the patient unable to suppress ADH secretion? And with that approach in mind, let's move on to the cases. Our first case is of a 28-year-old woman with a 3-day history of diarrhea found to have a sodium of 125. We start by going through the steps we outlined before. We find that she's asymptomatic, she's normoglycemic, and on history, she tells you she's been suffering from a GI illness for the past several days and has been making an effort to drink water to stay hydrated. On exam, she's tachycardic and orthostatic with dry oral mucosa. And with this data in mind, we try to answer the question, why is our patient unable to suppress ADH secretion? Based on the history in the exam, this seems like a classic case of hypovolemic hyponatremia, which is caused by volume depletion, leading to decreased effective circulating volume and non-osmotic ADH release. Since our patient has continued to drink water while in a high ADH state, she's continued to retain that water, even in the face of a depressed serum tonicity. Now, we could probably make this diagnosis based on the history in the exam alone, However, if we wanted to confirm the diagnosis, we could obtain some lab work. The most useful laboratory studies tend to be a urine osm and a urine sodium. You'll often see people order a plasma osm, but in general this tends to be unnecessary. The purpose of ordering a plasma osm is to classify the hyponatremia as either hypertonic, isotonic, or hypotonic. And as discussed before, by far the most common cause of hypertonic hyponatremia is hyperglycemia. Also keep in mind that an elevated BUN can lead to an elevated plasma osm, but we're not concerned with BUN since it's an ineffective osmol and doesn't contribute to tonicity. The point is that other causes of hypertonic or hyperosmolar hyponatremia are significantly less common, and you don't need to order a plasma osm to assess the glucose or the BUN, since these are typically available on routine lab work. As discussed before, isotonic hyponatremia is extremely uncommon, so in general, unless you're evaluating for an osmolar gap, which is not related to the workup of hyponatremia, obtaining a plasma osm tends to be relatively unhelpful, and the workup and thought process tends to be simplified if you don't even worry about it. As far as the urine studies, you should view the urine sodium as telling you about the effective circulating volume, and the urine osm as telling you about ADH. The urine sodium will be decreased, typically less than 25, in states of decreased effective circulating volume, since the kidneys are sensing decreased perfusion and thus are sodium avid, reabsorbing sodium along the nephron. The urine osm will be high, at least greater than 150, in high ADH states, since ADH promotes water reabsorption in the nephron, thus concentrating the urine. In coming back to our patient with hypovolemic hyponatremia, we would expect her urine sodium to be low, since her effective circulating volume is low, and the urine osm to be relatively high, since she's in a high ADH state. As far as management, the management of hypovolemic hyponatremia involves expanding the plasma volume, which will act to decrease the stimulus for ADH release. This is typically best accomplished with infusion of normal saline. Moving on to our next case, here we have a 64-year-old man coming in with worsening peripheral edema, elevated JVP, found to have a sodium of 125. We go through our usual approach. He's asymptomatic and normoglycemic, and on history, endorses worsening dyspnea on exertion, orthopnea, and lower extremity swelling, with a chest X-ray revealing significant pulmonary edema. And we conclude that this is likely hyponatremia secondary to advanced CHF. And this brings us to a discussion of hypervolemic hyponatremia, with common etiologies including CHF, cirrhosis, nephrotic syndrome, and some ESRD patients can also develop a hypervolemic hyponatremia. These patients are total body sodium overloaded with a decreased serum sodium concentration, again highlighting the discord between sodium content and concentration. Much like in the hypovolemic patient, these patients have decreased effective circulating volume, leading to non-osmotic ADH release. In heart failure, this is primarily due to low cardiac output and mostly due to vasodilation and cirrhosis. And it's very important to note that the development of hyponatremia is a poor prognostic indicator for both heart failure and cirrhotic patients. In fact, the new MELD score, which is used to evaluate mortality in cirrhotic patients awaiting transplant, incorporates the serum sodium as a predictor of mortality. The urine studies in these patients will look strikingly similar to the hypovolemic patient, since the pathophysiology is essentially the same. You would expect to see a decreased urine sodium concentration secondary to decreased effective circulating volume, and a high urine osmolality secondary to the action of ADH. It's important to note, however, that the urine sodium can be unreliable in these patients since they're often taking diuretics, which can elevate the urine sodium concentration. Management ideally involves correcting the underlying disease, but this is typically difficult. Giving more volume is not helpful, since it can worsen cardiac function and tends to simply be sequestered as edema fluid in the case of heart failure or as acidic fluid in the case of cirrhosis. The real staple of management for hypervolemic hyponatremia is water restriction. And this brings us to our last case, a 75-year-old woman with a history of depression, a new lung mass, found to have a sodium of 125. She's asymptomatic and normoglycemic, and on history, In addition to inquiring about her pulmonary symptoms and new lung mass, she tells you she takes an SSRI. On exam, she appears euvolemic with the findings as described below. And this leads into a discussion of euvolemic hyponatremia. These patients have normal total body sodium, but excess total body water. Now, as a quick aside, if you think about it carefully, these patients are actually slightly hypervolemic. And to understand why, let's review how water distributes in the body. For any volume of free water intake, 2/3 will go into cells, and 1/3 will go into the extracellular space. Of this 1/3, about 75% will remain in the interstitium, and 25% will go into the plasma. When referring to volume status, we're really talking about the extracellular fluid volume. Because these patients have normal total body sodium and excess total body water, a small amount of that water will remain in the plasma and the interstitium, making them slightly hypervolemic. However, this relatively small amount of added volume is not enough to cause clinically significant changes, and these patients will never be edematous on exam. The differential for euvolemic hyponatremia includes SIADH, hypocortisolemia, hypothyroidism, primary polydipsia, and the so-called tea and toast diet. And I put an asterisk next to primary polydipsia and the tea and toast diet, since these are the two exceptions to our general rule in that they're non-ADH dependent etiologies of hyponatremia, and we'll discuss them both more in a minute. Let's first talk about SIADH. SIADH is a true diagnosis of exclusion. There are clinical associations and lab values that may be consistent with SIADH, but there's no one finding that can make the diagnosis. You must first rule out hyponatremia secondary to other causes, and then see if your clinical and laboratory findings may be consistent with SIADH if these are ruled out. SIADH is commonly associated with both pulmonary and CNS disorders. Classically, small cell carcinoma of the lung can cause SIADH, although in reality, most lung pathology, even pneumonia, can cause excess ADH release. Many different central nervous system pathologies can also lead to inappropriate ADH release, with notable ones being stroke, hemorrhage, and malignancy. Lastly, there's a long list of medications associated with SIADH, with common ones being SSRIs, mood stabilizers, and some antineoplastic agents, for example, cyclophosphamide. On lab evaluation, the urine sodium is normal, or greater than 25, because these patients have normal effective circulating volume and thus are not particularly sodium avid. The urine osm is expected to be quite high due to high levels of circulating ADH. The other lab value that is consistent with SIADH is a high fractional excretion of uric acid. ADH itself causes increased distal secretion of uric acid into the urine. The question then becomes, why is the fractional excretion of uric acid not increased in all high ADH states? And the answer lies in that when the effective circulating volume is decreased, the kidneys are sodium avid, and uric acid is reabsorbed proximally along with sodium, and thus this reabsorption balances out the distal secretion. Whereas in euvolemic patients, proximal uric acid reabsorption is unchanged, and the distal secretion predominates. As far as management, water restriction is important, but these patients can also be treated with salt or urea tabs. In understanding why giving sodium to these patients is helpful, it's again important to think of hyponatremia as a water disorder. Since these patients are euvolemic, the sodium that's given doesn't stick around in the plasma. Rather, it should all be excreted in the urine. This in turn raises the urine osmolality and thus drags water with it, helping to get rid of free water. Giving urea tabs has the same effect. While we typically think of urea as an ineffective osmol, it can transiently have an osmotic effect since it equilibrates slowly across cell membranes and thus can also drag water with it in the urine. Hypothyroidism and hypocortisolemia can both also cause a euvolemic hyponatremia. The mechanism by which hypothyroidism does this is still mostly unclear. It's a bit more straightforward with hypocortisolemia, which causes decreased effective circulating volume and hypotension, leading to non-osmotic ADH release. It's important to keep in mind that in order to make the diagnosis of SIADH, you have to first rule these two etiologies out. and that can be done by obtaining a TSH and a cortisol. Now, before wrapping up, we have to touch on primary polydipsia and the so-called tea and toast diet. And I saved these for last because these are the outliers. They're the non-ADH dependent etiologies of hyponatremia, and thus don't fit neatly into the approach that's been emphasized throughout this talk, which is to ask, why is the patient unable to suppress ADH secretion? Fortunately, these are both relatively uncommon and are definitely the exception and not the rule. Essentially, they're both very similar and on the same spectrum, in which excess water consumption simply exceeds the kidney's ability to excrete all of it, even if ADH is entirely shut off. Now, to help explain this a bit more clearly, let's go through some basic math. In any given day, the average person consumes and excretes into the urine about 600 milliosms of solute. And the maximum amount that any person can dilute the urine is 50 milliosms per liter. And just to walk through the math, if we take in and excrete 600 milliosms of solute, and that solute is being excreted in urine that's at a maximally dilute concentration of 50 milliosms per liter, we'd have to drink at least 12 liters of water in order to get to the point where we're no longer able to excrete additional water, and the consumption of any more water will lead to the development of hyponatremia. And this is exactly what happens in primary polydipsia. But hopefully it stands out to you that the excess water consumption can't be trivial in order for this to occur. And of note, the older term for this disorder was actually psychogenic polydipsia, because historically it's more commonly been seen in psychiatric patients. The pathophysiology behind the so-called tea and toast diet is actually quite similar. And as an aside, if you've ever heard the term beer podomania, it's referring to the same basic idea. So let's say instead of consuming 600 milliosms in one day, a person only takes in 150. This means that assuming they excrete only 150 milliosms into the urine, and still a maximal diluting capacity of 50 milliosms per liter, they only have to drink 3 liters of water in order to overwhelm their kidney's ability to get rid of it. So in these patients, the way to think of it is as follows. The hyponatremia is not caused because they're not putting enough solute into the plasma, but rather because they're excreting less solute into the urine, which then lowers the threshold for how much water they would have to drink in order to overwhelm the kidney's ability to excrete all of it. And if you consume a diet low in solute and high in water, hence the names tea and toast or beer podomania, you become more prone to developing hyponatremia by this mechanism. In any event, for these patients, we'd expect the urine osm to be very low because ADH should be entirely shut off here. So with all of those etiologies in mind, let's wrap up this section by going back to our patient, a 75-year-old woman with a new lung mass and a sodium of 125. Clinically, she's euvolemic, she does not have evidence of heart failure or cirrhosis, she has a new lung mass, and we know she's been taking an SSRI. And on lab evaluation, we find that her urine sodium is 70, her urine osm is 500, her serum uric acid is 2, with a fractional excretion greater than 12%, and she has a normal TSH and a normal cortisol. So having ruled out other etiologies and putting the clinical history and lab data together, this seems most consistent with the diagnosis of SIADH.